Um, Imagine waking up one day and, finding out that the skin on, well, the absolute most sensitive part of your body is slowly turning into this rigid, inflexible parchment paper.
Yeah, that sounds like an absolute nightmare.
Right. And the crazy thing is, nobody can easily tell you why it's happening. So you're in pain, you're terrified, and because of exactly where this is happening, you are probably not talking to anyone about it.
Exactly. I mean, it is a profoundly isolating experience for the patients going through it.
Yeah.
And medically speaking, it's a landscape that can be incredibly murky to navigate, even for professionals, honestly.
Why is that?
Well, because the early signs often mimic, a half dozen other really minor issues.
Right, which makes it so easy to dismiss. So, we're taking you on a deep dive today into a condition that frequently just hides in plain sight, largely due to immense embarrassment.
Hmm.
Yet it has the power to fundamentally alter the male anatomy. It is called male genital lichen sclerosus, or LS for short.
Right, and clinically, you might also hear it referred to as balanitis serotica obliterans, or BXO.
Yes, BXO. And our specific mission today, the whole reason we're doing this deep dive, is to cut through all the confusion and answer one critical question. The question that, frankly, every single patient facing this eventually asks.
It is.
Is circumcision an actual cure for male lichen sclerosus?
Wow. Yeah, that really is the pivotal question, isn't it?
It really is.
And the answer, it actually challenges a lot of traditional assumptions about how we treat anatomical issues. Because this disease, it bridges dermatology, urology, and immunology all at once.
Exactly. It's so multi-layered. So to get to the bottom of it, we are pulling from a massive stack of sources today. We've got top dermatological guidelines from the British Association of Dermatologists, advanced urological clinic protocols, some really interesting aesthetic clinic literature.
Oh, the Swedish study, right.
Yes. A groundbreaking Swedish cross-sectional study that tracked 100 men over time.
We're going to put all these pieces together to figure out, what this disease is actually doing at a microscopic level.
Which is really where we have to start.
Right.
I mean, to evaluate whether surgically removing tissue is a cure, we first need to understand the invisible tightening that's happening to the body and, why the tissue is transforming in the first place.
Okay, let's unpack this. Let's get into the mechanics. From the sources, it's clear that lichen sclerosus is a chronic inflammatory skin condition.
Yes.
And in men, it primarily targets the uncircumcised genitalia, so specifically the foreskin, which doctors call the prepuce, and the glans, which is the head of the penis. But this isn't just a simple rash, is it?
Oh, no, far from it. It's much more insidious. The immune system is essentially staging this prolonged low-grade attack on this very specific, very delicate tissue.
So it's attacking itself.
Exactly.
Right.
And in the early stages, the signs are super subtle. You might just see some white, shiny, patchy skin.
But then the tissue starts losing its natural elasticity. It thins out, which leads to intense itching, a burning sensation, and the formation of tiny cracks, fissures, or even small blood blisters.
Oh, wow. And as that chronic inflammation just drags on for, I guess, months or even years, it triggers a really severe scarring process.
Yes, it does.
The medical literature describes a condition called phimosis, which is basically the inability to retract the foreskin, right?
Yeah, that's spot on. Basically, the body's repair mechanism just goes into overdrive. It replaces all that healthy, flexible skin with dense, fibrous scar tissue.
Right, and the clinical descriptions of this in the sources are really vivid. They talk about this phenomenon called wilding.
Oh, yeah, the wasting effect.
Yeah, so if a patient tries to retract the foreskin, it draws in around the shaft of the penis like a really tight band. I sort of pictured it almost like a piece of shrink wrap that's just been hit with a heat gun.
Yeah.
It just loses all of its natural give and rigidly locks down.
The shrink wrap visual is actually a perfect analogy. The collagen structure of the skin is being completely remodeled into something rigid.
Just totally inflexible.
Right. And because of that physical restriction, simple physiological actions, getting an erection, or honestly, even just the act of passing urine.
It becomes painful.
Incredibly painful.
Yeah.
Sometimes even impossible without causing the skin to literally tear and bleed.
God, that sounds awful. And knowing how severe and, frankly, visible those physical changes are, the delay in getting medical help seems completely baffling at first glance.
That does seem crazy, yeah.
But the sources highlight that men often wait years to report this. And, embarrassment plays a role, sure, but it seems like misinterpretation is an even bigger factor here.
Oh, absolutely. Misinterpretation is huge. Men see the redness and the cracking, and they just assume they're dealing with a minor fungal infection, like thrush.
Right, they think it's just a yeast issue or something.
Exactly. Or they assume the absolute worst and think they've contracted a sexually transmitted infection.
Oh, man. So they panic.
Yeah, they panic. So they try to treat it themselves with like over-the-counter antifungal creams from the pharmacy, or they just hide it out of pure shame, hoping it will miraculously clear up on its own.
Which is a tragedy because the medical consensus is definitive on this one point. Lichen sclerosus is absolutely not contagious.
Period.
It is not an STI. You cannot pass it to a partner, and you definitely did not catch it from someone else.
Right. It is entirely an internal inflammatory process. The danger in this case is coming from the patient's own biology.
Okay, so since we know this isn't a germ someone catches, the culprit has to be coming from inside the house, so to speak.
Exactly.
What exactly is triggering the body to attack its own tissue so aggressively? Because if we really want to figure out if surgery fixes this, we need to know what starts that whole shrink wrap effect to begin with.
Well, the underlying triggers are actually fascinating. One major factor identified in the clinical guidelines is something called the Kobno response.
The Kobner response, okay, if I'm understanding the sources correctly, that basically means the body is turning everyday friction into a weapon against itself.
That's a great way to put it, yeah. In individuals who are already predisposed to this condition, mechanical stress, trauma, or literally even simple friction on the skin triggers their immune system to massively overreact.
So instead of just healing a normal scratch,
Instead of just healing a minor microabrasion like it should, the immune cells flood the area, causing massive inflammation and laying down more of that rigid scar tissue we talked about.
wow.
It becomes this vicious cycle. But the most compelling theory regarding why the foreskin specifically is so vulnerable centers on this concept of microincontinence.
Okay, I remember reading this in the notes. So we are talking about urine actually acting as the catalyst here.
Yes. Think about the physical anatomy of an uncircumcised penis. The foreskin covers the glands, which creates a tight, warm, moist, and highly occlusive environment. After a man voids his bladder, a microscopic amount of urine, literally just a tiny drop, can easily remain trapped in that confined space between the inner layer of the foreskin and the glands.
And over time, that trapped urine acts as a chronic chemical irritant.
Month after month, year after year, that continuous low-grade chemical exposure irritates that highly sensitive mucosal tissue. And that sets off the inflammatory cascade that eventually leads to the severe scarring we see in LS.
But wait, are you saying a single drop of trapped urine is causing permanent severe scarring?
Well,
Because if that were the only factor, nearly every uncircumcised man on Earth would develop this condition, right?
that is an excellent point.
There has to be something else going on beneath the surface, like some sort of systemic vulnerability that makes only a very specific subset of men susceptible to this reaction.
And you hit the nail on the head. The medical community investigated that exact disparity, and it leads directly to the autoimmune link.
Okay, so it's an immune issue.
Right. The current consensus is that lichen sclerosus relies on a systemic glitch in the immune system. The patient's immune cells, specifically T cells and fibroblasts, are somehow primed to misidentify the body's own tissues as a foreign threat.
Oh, wow. So the microincontinence is the trigger pulling the lever, but the loaded gun is the patient's own overactive immune system.
That is the perfect way to look at it. And we see really strong evidence of this systemic vulnerability because men diagnosed with LS often have much higher rates of other autoimmune conditions,
Like what?
like thyroid disease or diabetes. The immune system is essentially misfiring on multiple fronts. And while this autoimmune link is, frankly, heavily studied in women who suffer from vulvar or lichen sclerosus, it is a critical underlying factor for men as well.
Okay, that makes sense. And while we're on the topic of triggers, there is this massive myth in the urology notes that I think we need to dispel right now.
Oh, I know the one you mean.
Yeah. A lot of people, and surprisingly even some medical professionals, assume that balanitis and LS are caused by poor hygiene. They assume the patient just, isn't washing thoroughly enough down there.
It is honestly one of the most damaging misconceptions in dermatology right now.
Really?
The clinical data shows that the exact opposite scenario is usually the culprit. Lichen sclerosus is definitely not caused by poor hygiene. In fact, many men suffering from these early symptoms are actually being too clean.
Too clean. Because they see the irritation and try to scrub it away with harsh soaps.
Exactly. They aggressively overwash the area with shower gels and heavily scented soaps. But the skin of the glands is incredibly delicate. By using soap, They are literally stripping away the tissue's natural protective lipid layer.
Oh, no. So they're removing the very thing protecting them.
Right. They're destroying the skin's barrier, which in turn allows those microscopic drops of urine to cause even more chemical damage, dramatically worsening that Koebner response we talked about earlier. This is exactly why the clinical guidelines strictly mandate abandoning soap entirely. You're only supposed to use gentle emollient washes.
Okay, so we have an underlying systemic immune glitch, which is triggered by a chemical irritant in the form of trap urine, which is then exacerbated by friction and the stripping away of the skin's natural oils by soap.
Yes.
I mean, that is a perfect storm for chronic inflammation.
It really is.
So if the immune system is the loaded gun, how do doctors actually disarm it on the front lines before they even consider resorting to a scalpel? What's the first step?
The absolute gold standard for initial treatment, and this is mandated by dermatological guidelines, is a very high-potency topical corticosteroid,
Okay, steroids.
specifically a medication called clobetasol propionate, and it's used at a 0.05% concentration.
Right. Applying a steroid of that magnitude to such delicate tissue sounds really intense. So applying this ultra-potent steroid is basically like putting a biological mute button on those specific immune cells. Like it physically blocks them from sending the chemical signals that create the scar tissue.
That is the exact mechanism. By applying it daily for 1 to 3 months, the goal is aggressive, localized immunosuppression. It forces the T cells to stand down and basically stops that faulty repair process in its tracks.
Makes sense.
And alongside the steroid, patients use thick emollients to create an artificial physical barrier. That protects the skin from further urine exposure and friction while it attempts to heal.
That's fascinating. And looking at the sources, they also highlight this really interesting shift toward regenerative medicine for this condition.
Oh yes, the newer therapies.
Yeah, I saw platelet-rich plasma therapy, or the P-shot, mentioned in the aesthetic clinic literature. And, I'm familiar with PRP because you always hear about professional athletes getting it injected into blown-out knees or torn ligaments.
Right, it's huge in sports medicine.
But how does spinning down someone's blood actually work to fix scarred skin on the penis?
Well, the principle relies entirely on the body's own healing factors. Doctors draw a small amount of the patient's blood, they spin it in a centrifuge to isolate the platelets and growth factors, and then they inject that concentrated plasma directly into the scarred penile tissue.
Wait, really? So instead of just suppressing the immune system like a steroid does, the PRP is actively trying to rebuild the tissue.
Yes, exactly. The concentrated growth factors signal the body to increase local blood flow and, more importantly, stimulate fresh, healthy collagen production.
Oh, wow.
And it actually helps break down and remodel the dense, rigid scar tissue that the lichen sclerosus has already laid down. It's an emerging adjunct therapy aimed specifically at restoring the tissue's lost elasticity.
Okay, that sounds promising. And this is but what happens if all of this fails? Like, if the biological mute button of the steroid just wasn't applied in time, and the scarring is so severe that the foreskin is permanently locked into that tight shrink-wrap state, because creams can't penetrate dense, fibrous scar tissue very well, right?
No, they really cannot. And if the foreskin is tightly constricted due to phimosis, the patient physically cannot retract it to even apply the medication to the actively inflamed areas underneath anyway.
So they can't even reach the problem.
Exactly. Once those structural changes are permanently established, conservative topical treatments become highly unreliable. The physical barrier of the scar tissue essentially dictates that we have to move to the ultimate intervention.
Which brings us directly back to the whole mission of this deep dive. The core question for you listening. If creams fail and the scarring is set, is circumcision the cure?
Well, looking at the broad clinical guidelines, circumcision is frequently described as the most effective, reliable long-term option. In urology, it's often considered the absolute mainstay of treatment for established stubborn disease.
Right, because it completely removes the environment where the disease thrives in the first place.
Precisely. A total surgical removal of the foreskin achieves 2 critical things. First, it physically excises the primary disease tissue, so the tightened, scarred prepuce is just gone. And second, and arguably most importantly, it eliminates that warm, moist, occlusive environment. Urine can literally no longer get trapped against the mucosal surface.
And without that moist environment constantly there, the head of the penis physically changes over time.
It does, yes.
Yeah.
The glans undergoes a process called keratinization.
Keratinization.
Right. This means the outer layer of cells toughens up and becomes dry, kind of similar to the skin on your elbow or the back of your hand.
Interesting.
It is no longer a delicate mucosal membrane. which thankfully makes it far less susceptible to chemical irritation. And for roughly 60 to 70% of men who fail medical treatment, this environmental change provided by circumcision acts as a permanent functional cure.
Okay, but 60 to 70% is definitely not 100%.
No, it is not.
And this is where that Swedish cross-sectional study drops a massive bombshell into the conversation, because they tracked 100 men diagnosed with LS, and their data on circumcision completely shatters the narrative that this surgery is a guaranteed magic bullet.
Oh, the Swedish data is incredibly eye-opening. It really changes the whole paradigm. They found that among the patients in their cohort who had been circumcised, an astounding 64% still experienced active lichen sclerosus after they recovered from the surgery.
64%. That is why the foreskin is the whole problem, and you completely cut the foreskin away. How on earth can the disease still be active in nearly 2/3 of those patients?
I know. And
That seems to completely defy the entire mechanical logic of the surgery.
it really seems counterintuitive. That is, until you remember the underlying autoimmune glitch we discussed earlier.
Right, the loaded gun.
Exactly. The surgery removes the foreskin, which is the primary driver of that occlusive, trapped urine environment. But the glands itself is still susceptible tissue. Furthermore, the Swedish study notes that circumcision often unmasks disease that was already brewing on the glands, but was basically hidden out of sight beneath the tight foreskin.
So removing the incubator, so to speak, doesn't stop the systemic immune system from attacking the tissue that's left behind?
Exactly. It proves definitively that male genital LS is a complex systemic inflammatory disease. It is not just a simple localized plumbing or mechanical issue.
Right.
The immune system is still primed and ready to attack that tissue, even without the foreskin there to trap the urine.
Okay, so this actually perfectly explains why the clinical guidelines are so incredibly strict about the specific type of surgery a patient gets.
Yes, absolutely.
Because the Swedish study also looked closely at men who received a partial circumcision, where a surgeon basically tries to just remove the tight, scarred tip, but leaves a portion of the foreskin intact, usually for cosmetic reasons or, functional preferences.
And the clinical guidelines now highly discourage that partial approach, for very good reason.
What happened in the study?
Well, the Swedish data showed that 9 out of the 15 men who received a partial circumcision developed constriction and severe scarring all over again in the remaining foreskin.
Oh man, so it just came right back.
Right back. The inflammatory process simply migrated to the tissue that was left behind. If a surgeon is going to alter the environment, it has to be a total removal.
But even with the total removal, as that 64% failure rate shows, the patient is still not entirely out of the woods.
No.
Which means we need to look beyond the foreskin. If the disease can survive the surgery, what is it actually doing to the rest of the anatomy? Like, what are the long-term stakes for the patient listening to this?
The stakes remain very high, unfortunately, because the inflammation does not necessarily confine itself just to the surface of the skin. Lichen sclerosus has a tendency to spread into the urethra.
Wait, the urethra, the internal tube that carries urine out of the body. So the shrink wrap effect can literally start happening inside the plumbing itself.
It can. When it hits the opening at the tip of the penis, it causes a condition called meatal stenosis.
Okay.
The opening severely narrows, which causes the urine stream to spray or dribble, and patients have to push physically hard just to empty their bladder. And if the scar tissue spreads even further up inside the urinary tract, it creates urethral strictures, which are these dense internal blockages.
That sounds excruciating. How do urologists even treat scar tissue that is hidden deep inside the urethra?
It requires ongoing, invasive urological procedures. Specialists have to routinely stretch or dilate the urethra with instruments.
Oh, wow.
Or they have to perform a metotomy, which is an actual surgical procedure, to physically cut open the narrow tip just so the patient can pee normally. It's a grueling cycle of management.
God, that's a lot. And beyond the excruciating plumbing issues, the sources point to a risk that is even more severe than that. There is a definitive cancer link to this chronic inflammation, isn't there?
There is. And this is exactly why accurate diagnosis and lifelong management are absolutely non-negotiable. The most severe long-term consequence of unmanaged lichen sclerosus is penile cancer, specifically squamous cell carcinoma.
Is that because the chronic inflammation essentially forces the skin cells to constantly repair and turn over, which just increases the chance of a genetic mutation?
That's exactly the mechanism. Every single time the tissue attempts to heal and is then attacked again by the immune system, the risk of a cellular error rises. The epidemiological data in the sources is honestly sobering.
What are the numbers?
Between one-third to one-half of all cases of penile cancer are associated with a background of lichen sclerosus.
Half of all penile cancer.
Up to half, yes.
That is a massive correlation, and this leads to a really critical takeaway for you listening right now. Lifelong self-examination and clinical follow-ups are absolutely vital. Even after a successful circumcision, even if your symptoms have been quiet for 5 years, you cannot just forget about it.
Never.
Any persistent ulcers, any hardened lumps, or any lesions that simply will not heal despite using the steroid creams, they must be assessed promptly by a specialist. They need to take a physical sample of that tissue, a biopsy, and look at it under a microscope to ensure it hasn't turned malignant. It is just not something you can ignore.
Vigilance is truly the only defense here. The risk of malignancy drops significantly once the inflammation is controlled by steroids or surgery, but the risk never fully drops to zero.
Right. So let's pull all of these complex threads together. We started this deep dive with a really specific mission. To answer the question, is circumcision a cure for male lichen sclerosus? And the answer, based on the clinical guidelines and the data we've unpacked, is a resounding yes, but.
Yes, but, exactly.
Yes, it is the most effective long-term treatment. It absolutely provides a functional cure for a majority of complex cases by physically removing the occlusive environment that traps the chemical triggers, but it is not a magic bullet.
Right. It is an environmental modification, not a systemic cure.
Exactly. Partial circumcisions almost always fail. The disease easily persists on the glands in a majority of patients, and because of the severe risks to the urethra and the looming threat of cancer, it just requires lifelong vigilance. You don't just get the surgery and walk away, right? You manage the condition for life in partnership with a dermatologist and a urologist.
It really represents a profound shift in how we view the condition. But if we pull back and look at the bigger picture of disease prevention, the clinical guidelines point out a statistical fact that leaves us with a truly fascinating biological mystery to ponder.
Oh, what detail is that?
So the epidemiological data explicitly states that lichen sclerosus is exceptionally rare in boys who were circumcised at birth. It almost never occurs.
Okay.
Now, if the trapping of urine, that microincontinence we discussed, is the primary environmental trigger that awakens the autoimmune glitch, what exactly is the chemical role of urine in creating this disease?
Oh, I see what you're saying. Because urine isn't just water. It is a highly complex chemical mixture of, like, urea, uric acid, salts, and all these bodily waste products.
Right. So what specific chemical compound in urine is interacting with that mucosal tissue to cause such a violent, localized inflammatory cascade? Could understanding the exact molecular reaction between urine and the skin unlock a targeted preventative treatment?
Like a specific chemical inhibitor that neutralizes the trigger before the scarring even has a chance to begin, which would basically render the need for surgery completely obsolete.
Exactly. If we can identify the specific chemical catalyst, we might be able to stop the Koebner response and the immune glitch before they ever even start.
That is an incredible thought. We know how to cut the damaged tissue away, but the microscopic chemical truth of exactly why it breaks down in the first place is still out there waiting to be discovered. We are leaving you with that medical mystery to mull over today. Thank you for joining us on this journey into the diagnostic muddy waters of lichen sclerosus. Keep asking questions, keep looking past the obvious, and we will catch you on the next deep dive.